Good afternoon, dear colleagues. I'm happy to welcome you to our symposium. It has very narrow subject, but I believe it is very interesting, and it is a pleasure to see so many young people. The symposium on pediatric cardiology has become a traditional part of this center, and we always have this symposium in the conferences. However, pediatric cardiology has become a real tradition because this dimension has become really very serious, very important, and our center is capable of providing high-tech medical aid on all the stages. So that is why this symposium during several days of the conference proves that experience that we have gathered by today within our center and within the country in general. This experience in pediatric cardiology is getting really more and more interesting for our audience, and it meets the requirements of the international audience as well. It is also with great pleasure for me to mention that this symposium is going to be attended by international colleagues. This is Karolinska University, the Department of Maternity and Childhood, and we also have representatives with this university, and we work on cardiomyopathy, especially in children, and in hereditary diseases, etc. So our first speaker is Gunnar Sioberg, with whom we have been in cooperation for such a long time, who represents Karolinska University Hospital. And many years ago, together we started this story of cardiology in our center and in our research, and this is going to be the first general presentation about cardiomyopathies in children and the approaches that we can witness today in this field. So, Professor Sioberg is going to share his presentation online.
My name is Gunnar Sioberg, and I'm a consultant in pediatric cardiology at Karolinska University Hospital in Stockholm. First, I would like to thank the organizers for letting me give this talk. And we'll start sharing the screen, where I will give an overview of inherited cardiomyopathies in children. And I will also relate this somewhat to the collaborations we've had over the Baltic Sea between St. Petersburg and Stockholm. It all started when Anna Kostareva came over to us for her PhD program, and we got an interest in not just myopathies, but cardiomyopathies, and also gave out a small review concerning structural proteins as a common cause of hereditary cardiomyopathies. So, if we look at the classification of cardiomyopathies, this was first in 1995. The WHO classification with a structural and division between the different cardiomyopathies into how they were phenotypically organized, with the hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and the unclassified ones that also included left ventricular non-compaction and Takotsubo cardiomyopathies. At that time, little was known about the genetics, but there were some new findings about the sarcomere being involved in the hypertrophic cardiomyopathies, the cytoskeleton in the dilated, and the desmosome in the right ventricular cardiomyopathy. However, it turns out to be more complex than this. Now, a more recent classification of cardiomyopathies has been done in Europe, where the cardiomyopathies are still divided similarly in a phenotypic way, but they have been divided into two different groups: the familial genetic ones and the non-familial non-genetic cardiomyopathies. And within the genetic ones, there are the ones that have an unidentified gene defect, and there are other ones that are known. But we will look specifically at the genetic ones. In North America, however, they have more looked at the cause of the cardiomyopathies and divided them into genetic, mixed, and acquired cardiomyopathies. And this is, of course, an attractive way to divide them, but also maybe less clinically relevant since we often diagnose the different cardiomyopathies from echocardiographic findings, for example. What are the challenges in the diagnosis of pediatric cardiomyopathies? Well, there are many different disorders that can cause a similar cardiomyopathy picture. One gene can, for example, cause different forms of cardiomyopathies. As an example, troponin I can cause as well hypertrophic, but also dilated and restrictive cardiomyopathies. And many genes can also cause the same type of cardiomyopathy. So dilated cardiomyopathy are caused by at least 50 known genes and hypertrophic over 80 genes. And on top of this, there's also varying penetrance and expressivity. So the different cardiomyopathies are, if you have the normal heart, the dilated is a dilated left ventricle most often, and often reduced contractility. You have the hypertrophic cardiomyopathy with a muscular left ventricle with a thickened muscle around it, and also often with a preserved systolic function, but a reduced diastolic function. And then we have the restrictive that looks similar in appearance as the normal, but here the left ventricle is stiffened and has a diastolic dysfunction. We have taken a special interest in the restrictive cardiomyopathies in our collaboration over the Baltic. And here are some of the publications that we've done together when it comes to restrictive cardiomyopathy. In one of our articles, we made a network of the different genes involved in restrictive cardiomyopathy and the different connections that they have, and it's a quite complex system. So it's not so easy as was maybe thought of from the beginning. Genetic causes of pediatric cardiomyopathy. We have different forms. We have the structural cardiomyopathies with the sarcomeric proteins and the cytoskeletal proteins involved that can cause all different kinds of cardiomyopathies. We have the metabolic cardiomyopathies with the inborn errors of metabolism and mitochondrial disorders that can also cause all different kinds of cardiomyopathies. Cardiomyopathies are also associated with neuromuscular disorders, and most common, of course, Duchenne-Becker's cardiomyopathies, but also other muscular dystrophies. Here, it's more common with dilated cardiomyopathies. And we also have some syndromes with the chromosomal defects or deletions or point mutations. One of the most common one involved in cardiomyopathies is the Noonan syndrome. And the funny thing is that we have actually had a collaboration in all these different groups between the two countries. Structural protein cardiomyopathies are divided, as I said, in the sarcomeric genes. And here we have all different genes involved in the contractile system of the cardiac muscle, with the troponins, and we have the myosin heavy chain, and we have the actin molecule. All of these can be mutated and cause cardiomyopathies, most often hypertrophic cardiomyopathies. And here we have also published a couple of articles concerning the troponin I gene. When it comes to cytoskeletal genes, these are the genes that are in the cytoskeletal system of the cytoplasma of the cardiac muscle. And here we have the intermediate filament desmin, for example, but also actin and titin that can cause different cardiomyopathies, mostly dilated ones. And also here we have had a lot of collaboration when it comes to these cytoskeletal genes, mostly desmin, but also, for example, desmoplakin. Inborn errors of metabolism is also an important group when it comes to cardiomyopathies in children. Here we have an epidemiology of 1 in about 800 children, and out of the cardiomyopathies, these are about 5% that are metabolic caused. Here it's mostly dilated cardiomyopathies, but also the other groups are involved. About 15 to 60% of all metabolic diseases are associated with also a cardiomyopathy, so it's quite common. You will hear more about the metabolic cardiomyopathies in a later talk, I think, but I've listed some of them here, and we have taken a special interest in the mitochondrial disorders. So the mitochondrial cardiomyopathies then can cause all the 4 different kinds of cardiomyopathies, and they can be with or without arrhythmias. They occur in about 20 to 40% of children with mitochondrial disease, and often with multiple organ involvement. Many different gene phenotypes are known. For example, everything from Barth syndrome and Friedreich's ataxia to MELAS and MERF. And at least 60 different genes are involved, including the primary mitochondrial disorders, genes involved in the electron transport chain and mitochondrial biogenesis, or secondary mitochondrial disorders involved in enzymes related to fatty acid and organic acid metabolism, but also to structural proteins connecting to mitochondria. And this is where we have also taken a special interest. So we've looked at different aspects of the structural cytoskeletal proteins involved in mitochondrial disease. Syndromes associated with cardiomyopathies. There are some, I've mentioned a couple here, Beckwith-Wiedemann syndrome with macrosomia, but that can also have hypertrophic cardiomyopathies. But most common maybe are the Russopathies, mostly exemplified by Noonan syndrome, which includes a very complicated signaling system, the Rus-MAP pathway. And here over 11 genes are involved in the mechanism causing the cardiomyopathies associated with this signal pathway. Noonan syndrome can be caused by many different genes, and there are also some associated syndromes that are caused by other genes. And they can cause when it comes to cardiomyopathies, hypertrophic cardiomyopathies, but there are also other cardiac defects such as ASDs and pulmonary stenosis that are common in these syndromes. Also here we've had an article published in this field. Last but not least, the neuromuscular disorders are also associated with the cardiomyopathies in children, and mostly dilated cardiomyopathies with or without arrhythmias, but also hypertrophic cardiomyopathies, restrictive and left ventricular non-compaction. Many proteins are common in common between the cardiac and skeletal muscle, and this mostly concerns cytoskeletal and membrane proteins when it comes to the associated dystrophies. The most common disorders are Duchenne-Becker with the dystrophin gene involved, but there are also other kinds of muscle dystrophies caused by other genes. And we've taken a special interest in the desmin-related cardiomyopathies, but also other muscle dystrophies and cardiomyopathies associated with this. And here we see 3 articles concerning the collaboration between our 2 groups involved in neuromuscular disorders and cardiomyopathies. So this was a short overview of the field of inherited cardiomyopathies and the collaboration between St. Petersburg and Stockholm within this field. And this has led over the years to over 26 publications and 2 dissertations at Karolinska Institute. And we're looking forward to continued collaboration, hopefully for many years to come. Thank you very much.
Often by the development of chronic heart failure, disturbances of the rhythm that results in sudden cardiac death. According to the data of the largest pediatric register cardiomyopathies, it was shown that metabolic cardiomyopathies in the structure of the entire cardiomyopathies account for 10 to 15%. That is a high figure, and it is very important to determine the cause of cardiomyopathy because possibly the substitution therapy will be possible in certain cases. There are some specific features of disturbance of metabolism which result in cardiomyopathies depending on the phenotype. The hypertrophic cardiomyopathy is most frequently associated with glycogenosis, determination of oxidation, phosphorylation, disturbance of the exchange of organic fatty acids and carnitine. Dilation cardiomyopathy is characterized by the disorder of carnitine exchange and phosphorylases and carnitine. In the 21st century, there are methods of diagnostic mass spectrometry and chromatography that reveal the cause of cardiomyopathy. So what happens in these cases? In these cases, there are three main standpoints. First, accumulation of products of metabolism in cardiomyocyte, cytoplasm, or organelles. Mainly these are lysosomes. And a second important process, disorder of the energy exchange. Disturbance of the energy exchange can't be well corrected. And we have to remember that the main substrates of energy exchange are fatty acids and secondary fat, glucose, and glycogen. So oxidation disorders of fatty acids should be early revealed and corrected. And finally, accumulation of toxic metabolites, which result in development of fibrosis and promote heterogeneity of myocardium and disturbance of cardiac rhythm. So what are the parameters of diagnostics of metabolic cardiomyopathies? It comprises three main statements. First, diagnostics of the lesion of myocardium and structural changes, dilation, hypertrophic restrictive phenotype. Secondly, metabolic cardiomyopathies are not monopathology or cardiometallurgy. That is a multisystem lesion, and the symptom of multisystem lesion make us think probably there are some metabolic disorders such as the cause of disease. And of course, we have to diagnose specific metabolic alterations. The onset belongs to the first months of the life, and probably there might be a form treatment, but particularly against the concurrent diseases, because at that time we have to provide metabolic support. What are the specific features of dilation cardiomyopathies of metabolic genesis? There are some specific features, and they have to be revealed early, and we have to think about the genesis. First, dilation, decrease of systolic function, and probably combination of dilation and heterogeneity of myocardium to accumulation of the products and high frequency of electric disorders, pre-excitation, fluttering, and weakness of the sinus node, and refractoriness to standard therapy of chronic heart failure is important, and giant T waves in case of dilation cardiomyopathy. There are some specific features of hypertrophic cardiomyopathies, that is a symmetric character, often non-obstructive forms, combination with a high frequency of electric instability, a hypertrophy of the auricles, and development of dilation and chronic heart failure. Please note extracardial symptoms of metabolic cardiomyopathies, because they make it possible to think there is a metabolic genesis of cardiomyopathies. These symptoms might be classified under general neurological, general facial anomalies, cataract, decrease in growth, liver dysfunction, vomiting, and skeletal disorders. Neurological, acute and chronic encephalopathy, myopathy, delay of mental development, and epileptic features. What should be taken into account when we conduct laboratory studies? Hyperglycemia, deficit of carnitine in blood, high acylcarnitine of fatty acids, high extraction of organic fatty acids, liver dysfunction. Very important is increasing lactate and pyruvate and metabolic acidosis. The most frequent causes of metabolic disorders for development of cardiomyopathy are the disturbances of carnitine exchange and beta oxidation of fatty acids. Let us consider the primary genetic defect of carnitine. Autism recession is inherited. There are two forms. Generalized form, very heavy, with the early onset, with a delay in physical and motor development of myopathy, with changes in CNS, encephalopathy, sometimes even Reye syndrome develops, and the more favorable muscular form associated with deficit of carnitine receptors. That form is characterized by low level of carnitine in muscles and myopathy. What shall we see when we analyze the heart? That is cardiomegaly, expressed systolic dysfunction, 0.03 ejection fraction, changes on ECG as giant T waves that correspond to the amplitude of Kore's complex. A very early onset, a disturbance of cardiac rhythm after development of a systole or ventricular tachycardia, fibrinolysis, and refractor chronic heart failure to the standard treatment. L-carnitine makes it possible to completely change the clinical character, to improve the prognosis, and to remove all the changes in the heart. Quite often, together with carnitine myopathy, particularly at an early age, incorrect diagnosis might be given, and there is a mask of myocarditis. For instance, the following observation: the boy retardation in physical and motor delay, quick, often bronchitis and respiratory diseases. Systolic functions were decreased and myocarditis was diagnosed. Everything was good, so to say, with infection. The child even had laboratory alterations, high titer of antibodies to cardiomyocytes. Treatment was given. Treatment did not give any effect. There was a wave-like procedure against the background of standard therapy. Thus, once again, we came back to the etiology of the disease. Once again, it was stressed that there is a delay in physical and motor development. There was a related marriage. There was no mitochondrial pathology. The level of lactate and pyruvate departed from the norm. At the same time, finally, the analysis of the level of free and total carnitine was given, and the level was 20 times earlier as versus the norm. Systemic deficit of carnitine was diagnosed. Verification of the diagnosis was based on genetic methods, and thus pathogenic treatment was administered that resulted in normalization of the contractility and normalization of the size of the cardiac cavities. How should we diagnose the disturbance in oxidation of fatty acids? In addition to the deficit of carnitine, which in that case is secondary, we have to determine whether there is a decarboxyl aciduria. If it is there, there is a disorder in oxidation of fatty acids. If it is not present, but if there is a reduction of the level of carnitine and higher acylcarnitine, we diagnose a disorder of carnitine-dependent transport of fatty acids. Generally, cardiomyopathy associated with disturbance of beta oxidation covers a large heterogeneous group of diseases. It is known that phenotypic shows might be different. This might be dilation, hypertrophic cardiomyopathy. Noteworthy is that there is a high frequency in recent disorders in ectosystole and complete blocks and dependent. Determination of specific metabolic mechanism helps to timely administer the pathogenic treatment, antipathogenic treatment, because that is the disorder in carnitine, and certain L-carnitine drugs are given. Mitochondrial cardiomyopathy, what are its characteristics? There is a disturbance in oxidation phosphorylation in mitochondria, and thus the development of energy insufficiency and the development of hypertrophic or dilation cardiomyopathy. That is a polyorganic pathology that distinguishes it from other forms, and thus disturbance of the central nervous system, encephalopathy, and growth retardation, stroke-like episodes, a disturbance of vision and hearing, because these are the most sensitive organs to the energy deficit. And finally, how should we diagnose these patients? It is quite simple. High level of lactate and performate and metabolic acidosis. Typical mitochondrial syndromes are known, such as Kern's syndrome that mainly shows us, but full ventricular block or probably dilation and hypertrophic cardiomyopathy and polyorganic lesion, low hearing, and the development of total blockade blocks requires implantation of the pacemaker. Another typical mitochondrial syndrome is Smelly Syndrome. It is characterized by encephalopathy, lactate acidosis, stroke-like episodes, and formation of dilation of hypertrophic cardiomyopathies. These are our observation: dilation cardiomyopathy, disturbance of perfusion in a girl, and that can be treated by energy substitution drugs. Not always mitochondrial cardiomyopathy is accompanied by such clear polysystemic and syndromal shows, and it might not be differentiated sometimes. These are our observations that support that standpoint. A girl, and before 8 months, developed well, and she could walk. At a year and a half, there is a myotonic syndrome that is quite important. Then ataxia developed that is also an important show. As to the heart, nothing was determined. Prolapse of the mitral valves and open of the window. Noteworthy was the increasing level of lactate and retardation in physical development. At the age of 8 years, there was an onset of the disease. There was a chronic heart failure, which rather quickly developed, and the ejection fraction at that time was 23%, so it was rather difficult to treat that girl. So what was revealed afterwards? Typical RF fibers were recorded in high concentration that confirmed mitochondrial pathology. And finally, genetic testing was conducted, and mutation in gene of RNA transport was recorded, and then energy therapy by L-carnitine and coenzyme was administered. Of course, it was late, and cardinal leveling of the changes was not so easy. A very important syndrome, that is birth syndrome. This is the most frequent cause of dilation cardiomyopathy in boys of the first year of life. Why in boys? Because that is inherited, typical triad dilation cardiomyopathy, melatonia, and metabopathy, and neutropenia. It is inherited. The cause is the defect in tyrosine gene, and tyrosine is the gene that controls the level of cardiolipin and the function of mitochondrial membranes, and thus the disease is characterized by carnitine insufficiency and mitochondrial insufficiency. And the main changes in the heart are as follows: expressed, pronounced fibrinolysis, in addition to dilation cardiomyopathy, the syndrome of non-compact myocardium, and quite often because the disease is verified against a background of intercurrent disease, it is not completely, it is not correctly diagnosed as myocarditis. There are some symptoms of extracardial lesion, endocrine delay in growth, neuromuscular neuropathy, neurological difficulty in learning up to the stroke, hematological neutropenia, and neutropenia against the background of infection develops a higher risk of sepsis development, which is often the cause of death. Besides, gastric and intestinal disorders, enterocolitis might develop. And from the facial skeleton, there are full cheeks and deep eyes. The main metabolic disorder is the increase of methylglucagon acid. The increase is 20-fold against the norm and the lower level of carnitine. A boy from the first pregnancy, from the 5th day of life, had respiratory insufficiency and leukopenia and neutropenia, the main symptoms. He is diagnosed as a myocarditis, chronic heart failure, and he's treated according to the diagnosis. Only at 6 months, when he is brought to consultation, we determined the increase of 3-methylglutagonic acid, and thus we thought that that was Bell's syndrome, and further, it was verified by the data of genetic tests, and finally, energy substitution therapy, such as carnitine coenzyme, was administered that increased the level of carnitine and improved the condition of the baby. Less frequently, but shows up in hypertrophic cardiomyopathy, and another observation that is an exclusive case from the first month of myopathy, somatotype symmetric non-obstructive cardiomyopathy, transitory neutropenia, and first it was regarded as the primary hypertrophic cardiomyopathy only in 1 year, when we verified the disorders in 3-methylglucagonic acid, and we revealed the surgery. He was diagnosed as Bart syndrome, and ergometin coenzyme was administered. What can we see by the age of 17? According to the parameters of physical development, he didn't differ from the norm. The metabolism and beta oxidation of fatty acids became normalized then. Another cause of disorders in metabolism that is characteristic of hypertrophic glycodenosis. We know the infantile form of Pompe disease. There is a lack of mutation in the gene of lysosomal acid. Then there is a disorder in glycogen degradation that accumulates in cardiomyocytes and in muscles. So in addition to hypertrophy, there is a hypertonia. It is important to diagnose it, and currently, as to the diagnosis, there is no problem, because we use screening as blood stains, and the earlier we administer enzyme substitution therapy and mycin, the better would be the forecast. There is a late form of Pompe disease that is not accompanied by such a bright extracardial shows. Therefore, screening for Pompe disease has to be conducted in case of the forms that similar to primary hypertrophic cardiomyopathy, another metabolic form associated with accumulation of glycogen, which mainly is accumulated in cytoplasm of cardiomyocytes, the so-called isolated glycogenosis of the heart. It is based on the deficit of cardiac AMF, phosphorylate kinase, which there is a hypertrophic cardiomyopathy that is associated with pronounced bradycardia. What is bradycardia? Bradycardia is the impossibility to administer beta blockers and blockers of calcium channels. At the same time, in 50% of cases, there is a syndrome of WPW that results in supraventricular tachycardia. In this case, we have to early diagnose the disease, and it differs from classical cardiomyopathy, that is diffuse hypertrophy, not only in ventricles, but also in auricles. Syncope and dizziness against bradycardia. What is it? That is overture in case Whipper syndrome and implanting. It's better to implant pacemakers immediately, because a pacemaker would solve two problems: remove and correct bradycardia and prevent the development of ventricular fibrillation against ventricular tachycardia. And another form of glycogenosis, the so-called Danon disease. What happens in case of Danon disease? Glycogen, against the background of mutation of lysosomal protein, is accumulated mainly in lysosomes. Lysosomes degrade. There is a pronounced fibrosis and a pronounced vascularization of cardiomyocytes. At the same time, there is an extreme hypertrophy of the cavity. There is no cavity of the left ventricle. The thickness of myocardium is 40-50 millimeters, both at the interventricular septum and at the back wall. What is the essential difference of that pathology? That is the Smelly Syndrome. It is also characterized by Wolff-Parkinson-White syndrome, the extremely hypertrophy, VPV syndrome, and that is also observation verification as revealing a mutation in gene LAMP-P2 membrane protein. Besides, a very important factor, extreme hypertrophy, or the level of troponin increases extremely, and the level of cerebral natriuretic peptide also increases, that is related with extreme hypertrophy. And there are some specific features, such as implantation of cardioverter defibrillator, extreme, the electrode with one shock spiral is not effective for ventricular fibrillation, and electrode with two shock spirals is used. And finally, early diagnostics of metabolic cardiomyopathies makes it possible to timely start the therapy. In certain cases, that results in significant improvement or liquidation of structural disorders. Besides, metabolic therapy significantly improves the prognosis for cardiac insufficiency and for heart failure, and thus we help the people. And to conclude, these are the words of the researcher of the 15th century, Niccolo Machiavelli. That is, it is easy to treat the severe disease at the beginning, but it is rather difficult to recognize it when it became more severe. But it is easier to recognize it, but it is more difficult to treat it. Thank you very much. Thank you, Irina Viktorovna. Allow me to ask one question. Among the metabolic cardiomyopathies which you discussed, do you have any observations of patients with SWAP mutations that onset at the pediatric age? Commonly, the debut is an adult age. Are there any specific infantile features of forms? 5 patients with Danon syndrome are recorded, and the mutations. We have 4 patients with PERCA G2 mutation at an early age, a boy with primary, no microphone. Microphone is switched off. I can't hear. Despite the fact that that is a severe course, when we administer carnitine, we could improve the prognosis. We never expected it, and now there is no dilation, and there is no reduction of systolic function. Ejection fraction is 5. There's no myopathy. So mainly that is an early pediatric age and a disturbance of oxidation of fatty acids. This is at an early age, to say nothing about Pompe disease. I am asking about the patients with SPERCAG2 mutations. Those pediatric cases which you recorded, were they primary patients or were they relatives or children of the adult carers? These were primary patients, and 4 patients we had mutations of de novo. Thank you very much. That's a very interesting observation, because these are quite rare, probably even unique forms that you managed to diagnose. We have been doing it rather long ago. We never thought previously, we didn't know how to treat bradycardia. Genetics was not used in the 90s in clinical practice. That started in the 90s. And now practically we know what is bradycardia, and we have to look for mutations in this case. Thank you, Irina Viktorovna. We continue our symposium. And I would introduce myself. And I will speak about a more detailed consideration of the syndrome of non-compact left ventricle in children.
So the form of LV non-compaction is one of the forms of cardiomyopathies, as it has already been mentioned in different presentations and European classification that is mainly based on structural changes of myocardium. It is a part of non-classified cardiomyopathies. As for previous types, everything is clear, but as for the group of non-classified, then here we have only left ventricular non-compaction. So the question is, why not just have this separate group, LV non-compaction? Probably the reason is that probably there are some forms that are more or less close or similar or overlapping, and sometimes a patient may transform its phenotype during the course of type, especially if diagnosis is done during the childhood and we follow up the patient. And if there are some other manifestations of cardiomyopathies, then this is a non-classified form. The history of TOR dates back to 1969. Functional diagnostic and visualization were not really developed those days. And the first time it was described with a sectional material of a severe clinical case that was described in a child, and in children those forms are really severe. So those were the data given in 1969, when compact part prevailed over non-compact part and contractility was reduced. Later in 1975, first cases of non-compaction were identified with thickness of endocardium, and of course those were also severe clinical cases with poor prognosis. The next stage of this study happened in the 90s with the help of ECG and MRI, and the first criteria of non-compaction appeared. And then later, in the 21st century, the genetic diagnostics appeared, and the first genes that were connected with non-compaction were discovered. We understood that this syndrome can be a part of other cardiomyopathies. that has been mentioned by Irina Viktorovna. It can be appeared in neuromuscular disorders, for example. Non-compaction is caused by embryogenesis of the heart, when in the early premature period there is no coronary artery. And this substance for this sponge matter is necessary when the blood penetrates into cardiomyocytes, and this is how it feeds myocardium. And on the left, you can see this process that takes place at the end of embryonic period with the compaction, when this thickness of the sponge matter goes down and myocardium becomes thicker. And if there are genetic defects, different mutations that may occur and that define further development, then at this stage the development of myocardium may take place. And here you may see that a thicker layer does not prevail over the sponge, and it entails a poor contractility. So in adulthood or even in a newborn child, we can see that this non-sponge matter prevails the sponge matter. And we can see this relation of these two layers either in ECG or with the help of MRI. And in order to have this diagnosis of non-compaction, the sponge layer should be twice as thick as the other layer. This correlation is always criticized, reanalyzed, and there was a German research that proved that 4% of healthy people they have this criteria that is very close to non-compaction, according to MRI. However, we do not have other criteria for today. However, there are publications, and in these publications there is a new term. This is a phenomenon of non-compaction. This is the state or condition when this layer is less than 2 but more than 1.5, and this is a kind of substrate for a disorder of contractility and heart remodeling. It may also occur in other cardiomyopathies. The first information about genetic specter of the disease also appeared quite a long time. That was connected with the Bartter syndrome, because one of the first manifestations of Bartter syndrome, and this is dilatation CM in boys, is non-compaction dilatation, and it was caused by gene topozyme. Moreover, other genes were also described that are responsible for non-compaction. That was in the very beginning of the 21st century, and genetics was developing very fast, and the first impression was that these should be a separate group of genes that do not overlap of other cardiomyopathies, because, for example, the first gene that was described after topozyme, that was dystroproline, that codes a protein of sarcoglycan complex, and we do not witness it in other cardiomyopathies. It is not actually described. But with development of genetics, this gene that was first discovered occurs actually very rarely in non-compaction, and the main reason for non-compaction are genes that are connected with mitochondrial function, or, as I've already mentioned, extracellular matrix, or mutations in sarcomere protein, what we often see in cardiomyopathies. Cipher gene was described also among the first one, and it also ensures mechanical stability of the heart, and the membrane gene. So in fact we have the same genes, and their composition and list is more or less the same for different cardiomyopathies. Today it is quite well known that there is no non-ambiguous correlation between genotype and phenotype, and with all cardiomyopathies any mutations may take place, and a mutation in any gene may entail a formation of this or that phenotype. Then a non-compaction, that is marked here with green, shows that quite a large spectrum of genes, quite different in their function and that code ionic channels, metabolic ferments or enzymes, all of them may entail non-compaction. And there is also quite a lot of transcription genes and embryogenesis. For example, non-compaction was described with extradycardia, with different organ disorders. So the lesions were quite severe. So there was a hypothesis that non-compaction is not just a form of CM, it is a form of unfavorable remodeling that myocardium may suffer because of different genetic or phenotypic reasons, for example, during stress or some unfavorable factors. So any trigger or any toxic impact or metabolic impact or any gene defect can trigger metabolism, either HCM or other cardiomyopathy. So that is why the genetic spectrum of non-compaction is probably the largest and the broadest for today. However, on the other hand, there are no understanding which signal pathways are involved. The research that we tried to analyze proved that everything was dependent on the group, on the size of the group, what genes were included in the research, and in particular there was a group of 200 people, and it was shown that the main gene that is connected with non-compaction is titin gene. You can see it on the left part of the slide. It accounts for 20% of cases, and there were also other genes. You can see them also on the slide. After quite a large meta-analysis of 7,500 patients, these data were proven, and of course it was proven that it is titin that is connected with non-compaction. But we should also remember that titin is the largest gene that codes the largest protein, and actually each of us has its own unique variant of this gene. We are carriers of these unique variants, and its pathologies and correlation with non-compaction is quite a question today. Here you can see another research about genetic spectrum of cardiomyopathies. Here 95 patients were covered, and quite a lot of patients among them had mutations in sarcomere gene, but those were adult patients with prevailed sarcomere mutations. There were mutations in gene ionic channels and in some other genes. However, when we tried to compare or correlate genotype and phenotype, please pay your attention to the right. There were no significant changes, regardless what was the genetic reason for this myocardium, for non-compaction. The result is more or less the same. However, we should remember that those were adult patients. Today, non-compaction includes or described as unfavorable remodeling of a heart under the impact of certain factors. It can be non-compaction itself, it can be non-compaction cardiomyopathy, and then it may also transform to dilation cardiomyopathy with non-compaction. What is a clinical course of non-compaction? 10% of these patients are candidates for cardiac transplantation, and quite often these patients have certain comorbidities, like for example neuromuscular disorders. And as for ventricular arrhythmic disorders, which seems to be quite expected to be quite typical, and it is occurred in 20 to 30% of cases. But the most often attribute is conduction disease. It is not often described because classical non-compaction is dysrhythmia. However, conduction disease is also quite frequent, and it is mostly frequent in children, especially when non-compaction is associated with inherited cardiac failures. These patients have a worse prognosis. Here you can see the survival rate, and non-compaction worsen dilation cardiomyopathy, and they deteriorate prognosis. But in combination with HCM, the prognosis is not worsened. It is mostly frequent in women, and there is a reverse correlation with wall thickness. Quite often it is absorbed in symmetrical forms of HCM, and there is no prognosis and no risk of sudden death. However, in children, there are certain peculiarities of clinical course, and they were very well shown by the previous speaker, because in fact, those are the most severe and unfavorable from the viewpoint of prognosis cases. First of all, 9 to 10% of these patients are expected to have heart transplantation. Quite often they have WPW syndromes, and if we compare the group of unfavorable course of the disease here, you can see to the right the statistics difference, and these are the patients that start with a lower ejection fraction. They have also heart failure syndrome and non-compaction of both left ventricle and right ventricle, and this is the most unfavorable prognosis. If we compare HCM and LV non-compaction, here we can see that HCM have better prognosis, and as for non-compaction, they have a worse prognosis if we compare them to children just with HCM. Here you can see another quite difficult slide for understanding. However, I am going to comment on this. The upper green light shows patients with non-compaction phenomena without heart remodeling, without signs of DCM, and without heart failure. So in fact, non-compaction criteria by themselves, they are of quite favorable prognosis, but with dilatation, with hypertrophic, then in this case the prognosis worsens, and more often they reach their endpoints as a heart transplantation. And the last quite significant research that cast light upon LV non-compaction was a research that dates back to 2018, and there were 52 children covered by this research and 275 adults, and all of them were genotyped. And from these two diagrams you can see that there are features of genetic background in children. Here we can see the prevalence of sarcomere variants and ionic channels. As for adults, there are no these channels among them that are responsible for LV non-compaction. This is another diagram that shows that it is in children non-compaction has a worse prognosis than if we compare it to adult group. And if we compare this non-compaction juvenile form or infantile form before 1 year of age, and we compare it to juvenile, then the start of non-compaction in infantile form has worse prognosis. But this is quite typical for medicine and for heart failure, general prognosis for heart failure. Another unfavorable predictors are thin wall of myocardium, less than 1.5, and low ejection fraction and heart failure. In our center, we have quite a lot of these patients. They are observed and followed up. We have a possibility to conduct phenotypes, including also new methods. And we researched and analyzed a group of 20 patients. And we included also patients from abroad, from countries, from other countries. And here we can see the data that are more or less similar to international data. The severe heart failure in 10% cases entails in cardiac transplantation. Quite often it is associated with inborn heart failures and septal defects and supraventricular tachycardias. As for birth syndrome, we have already heard about it today. It is one of the most frequent variants, and in our group of 20 patients, we had 4 patients with birth syndrome. One of these patients died, unfortunately. Others have quite a favorable course of the disease. And I'd like also to mention that this syndrome may have unfavorable prognosis if it takes place in the first 2-3 years of age, but after 5 years of age, children have better prognosis, and probably it is this gene responsible for cardiolipin plays less significant role, or probably mitochondrial function is compensated. So patients after 5 years of age have better prognosis, and it is connected with the fact that before that the mortality level was also significantly higher. I do not know the exact statistics for today, but definitely it is much better than 20 years ago, when possibilities were significantly limited in treating heart failures in children. To conclude, I'd like to mention that non-compaction is a very genetic heterogeneous group, and I would describe it as not as a separate group of CM, but it is a remodeled heart caused by different genetic factors. As for a clinical course in children, it is less favorable than in adults, and quite often it is combined with heart failures. Predictors of bad prognosis is lower ejection fraction and heart failure, and more often than non-compaction is caused by gene mutations that code ionic channels and other metabolic genes. Thank you very much indeed for your attention. I think that now it's time to give the floor to our next speaker. We are within our time limits, and now I would like to introduce our German colleagues, Professor Hendrik Milting, and has a presentation about familial screening in SCD victims and clinical and genetic aspects. So the floor.
Okay, good morning. Can you see the slides? Okay, so I will present on familial screening in sudden cardiac death victims, and I've expanded a little bit the title, Clinical, Genetic and Historical Aspects for Certain Reasons. But first of all, I would like to introduce myself. So I'm coming from the Heart and Diabetes Center in Bad Oeynhausen, which is in the western part of Germany, and it's located in a rural area, and is part of the Ruhr University in Bochum. So actually, our center is quite a distance away from our campus, so it's about 170 kilometers. So we are located here in the very east part of the country, North Rhine-Westphalia, and this part here plays a certain role for the study data I would like to share with you. Okay, so what is particular in Bad Oeynhausen? What is the special condition here? Well, what you see here is the statistics of the German Society for Organ Sharing, the DSO, and the statistics you can see below, and you will see that Bad Oeynhausen is the largest heart transplantation center here in Germany, and especially also in the European Union. So what you see is on the right side some digits on the clinical performance of this center, and you see at the top a pedigree, and this pedigree explains why we as a transplant center have a special interest in genetics as well. You see a pedigree of an ARVC patient shown in red, And you see also some other members in this family we never have seen here in our center because they died by sudden cardiac death. So sudden cardiac death is one aspect of severe cardiomyopathies, and this is why we had a certain interest in this particular genetic entity. Well, what you see here is especially those severe cases from our clinics. You see that even pediatric patients might be affected by mutations and need mechanical circulatory support, as you can see here by a bivet with a burden heart. And we have heard before an excellent talk on genetics of early childhood cardiomyopathies. But you see then on the right side are also cases from sudden cardiac death cases, myosin binding protein C, for instance, from an autopsy, and you see from transplant also cases from ARVC with a particular PKP2 mutations, which are typical or are frequent for this kind of disease, as we have heard before from Anna Kostareva. Well, how can you identify a genetic disease? Obviously, when you have a pedigree, you can easily detect this when you ask the members of the family. But what happens if you just have such a pedigree? Well, this pedigree is taken from our study, and I will come to that family back later. And what you can see is that there's only one patient affected by this disease, and nevertheless, this patient has a genetic disease, not a familial disease. So this is what we observed in our center, so that the majority of especially young patients below 40 years have certain genetic conditions which are belonging to the class 5 or 4 classification of genetic diseases. So in other words, there's a genetic precondition why this disease is occurring in end-stage heart failure patients especially. Well, you might argue, well, when it comes to some cardiac death, well, you will get some material from autopsy, and this is indeed one source for DNA if you would like to unravel why a certain patient died in early childhood or at early age. What you see here in the middle of the slide is the DNA, and the DNA from 2 different sudden cardiac death victims. And what is remarkable here is that all these samples were collected in a proper way by a forensic department in Hamburg, but you also can see that the DNA is degraded, and this DNA is not suitable, cannot be used for high throughput screening anymore because the quality of the DNA is really affected. And this led to the situation that we were not able to analyze the sudden cardiac death of a number of cases, and we received the idea that during resuscitation, the emergency medical service might save the DNA because this might have some advantages. So what is the condition? What are the guidelines recommending so far? So on the left side, you see in 2015 from the European Resuscitation Council, there was a report and the guidelines was recommending screening for inherited disorders. Well, you have seen before, it must not be inherited, it might be spontaneously occurring in a family. So a de novo mutation might also be a problem. So they recommend in selected cases to genetic mutations associated with inherited cardiac diseases should also be searched. This has been in 2015. So when you look at the most recent guidelines, you see the genetic test should be performed initially on the DNA, etc., etc. So in other words, the emergency medical service might contribute to this, but clear guidelines are lacking. Who should do this and in what case? And this is really a problem, as you might see and appreciate from the next slide. So what you see here is what happens in Germany, and this happens as well in other countries as well. So when you have a sudden unexplained death, the emergency medical service will come and the police as well. And then there is a decision between natural and non-natural death. And if this is a non-natural death, the police will initiate an autopsy by the forensic departments. And when you are lucky, you will have a molecular autopsy as well to unravel a genetic condition of the natural death, which is really behind that sudden unexplained death. and maybe you can unravel the cause of death. But when the police is not, and the prosecutors decide not to do an autopsy, the family is responsible to decide what will happen. If this is done in a pathology department, they have to pay for this. But if they decide not to do a pathologic autopsy, the cause of death remains unresolved. And when a family is behind that, a family disease, this might be fatal to other members in the family. Well, we decided to start with the MAP-IT study, and included patients in a prospective study, all out of hospital cardiac arrest cases between 1 and 50 years. So this is a broad window. We are fully aware on that. We excluded forensic or traumatic cases, polytoxic cases, of course, acute myocardial infarctions for certain reasons, and chronic diseases, no palliative care diseases, and no suicides, of course, they were not included. If you have no acceptance of the analysis, you will also exclude those patients. So what we did was we evaluated in the very eastern part of the country, North Rhine-Westphalia in Germany, because the logistics is really is just a hell in such a study. You have to coordinate a number of administrative entities and a whole bunch of persons who are involved in such a study. But nevertheless, we were able to evaluate 39,000 emergency medical service protocols in total. We identified CPR cases 769 in about 2 years. And we extracted CPR cases between 1 and 50 years, 103. And of those patients, so the median of these cases is 37 years. And what we did was we checked also the clinical data of these families, of these cases. So 3/4 of these cases have been males, and this is not a surprise. This fits to other data in the literature. And what we also observed was 25% of those cases were discharged from the hospital, whereas the majority of cases died, although the EMS was in charge. So this is also quite usual when you compare this to other cohorts. And what was also interesting to see was those patients who were finally extracted from those 103 cases, the majority of those cases were in fact not autopsied at all. So this is quite usual, and this happens to other cohorts. It's the normal situation in clinical practice. So when you look at the data, we extracted finally 24 patients which fitted our inclusion criteria, and when you compare this to the smaller group of patients, 37% were discharged, but the majority again were died during these resuscitation procedures. And we genotyped those patients not by whole exome sequencing, but by panel sequencing so far, because this might be done in a molecular autopsy as well, and in diagnostics as well. And what you see here is the evaluation of those cases. You see that the ACMG cases, 4 or 5, so pathogenic or probably pathogenic cases, were six index patients. And you see those gray shaded column parts here represent those cases who did not survive. You see that 2 of them were autopsied, whereas the majority of cases had ACMG3 variants, and a number of them were also autopsied, but a minority of these cases have been autopsied at all. So this is what we summarized then. 25% had severe mutations, variants which are related to the sudden cardiac death. The majority of those were unknown cases, but what was interesting is to see was one of those cases here, the red dot, for instance, which in the panel sequence had variants with ACMG3. This patient had a clear familial disease, so we are doing currently a whole exome sequencing in this case. And another case, which who was originally an ACMG3 case, were proven to be a carrier of an ACMG4 mutation by whole exome sequencing. So he was located here in this part of the graph. So in other words, we found a number of cases which would have not been identified without the activity of the emergency medical service. Well, to our surprise, a number of those cases were from Russian origin. These are different newspapers. So this is a local newspaper with Jens Thiesmeyer. He's the emergency medical doctor involved in the study as the head of that clinical part. You see the Russian German, the Moscow Germans paper, which is a paper published in Russia from a group of Russian Germans still located in Russia. And we had here in Bad Oeynhausen, we had a delegation from that group, and they were interested in what we did here, and they reported also on the German-Russian heart affair. Okay, so what you see here, what happened was that we identified in the first case a 19-year-old boy, and you have seen this pedigree before, and you obviously can see from the autopsy, this is a hypertrophic cardiomyopathy. He died while walking to school suddenly, and the disease was not known before. And it appeared that this patient had a FHL1 mutation, a truncating version of that truncating variant. And the interesting thing was that this mutation, this gene is located on the X chromosome. So the truncating mutation in FHL1 was classified as class 5, whereas the myosin binding protein C was probably pathogenic and was classified as ACMG4. So this is the histology of the patient. You see a severe fibrosis was you could macroscopically see in this at the border side here of the ventricles, but on the microscope you can clearly see there's lots of fibrosis in there. And what you see here is immunohistochemistry of the left ventricle and of skeletal muscle and left ventricle from the patient. So these are controls. And what you see here is FHL1 positive staining, whereas it is completely lacking, which is supported by the Western blot when we looked at the protein here and the in the ventricle and the muscle tissue. And due to the fact that this gene is located on the X chromosome, he's the only one, or he has the only version of this protein is destructed, and for this reason, this is a complete knockout for, in fact, a functional knockout of this protein, which explains what happens here in that family. So we identified that the mother who was providing the X chromosome was wild type for this for this mutation. So this is a de novo mutation on the X chromosome, which finally killed this patient. Well, there has been a second family, and by chance, this was also a Russian-German family. And this was also a surprise to us. This patient died by sudden cardiac death, and he was autopsied by a forensics department because he died while Skyping with his friends in Russia. And the mutation we identified was in the myosin binding protein C again. And this was a truncating mutation, which led to the situation that the rest of these important domains of the proteins were lacking completely, or in other words, the protein was degraded. So functionally, it was it led to the degradation of half of the myosin binding protein C's expressed in the myocardium. Well, at the same time, we had in the clinics another Russian-German family, and this Russian-German family had a Mennonite background. And what you see here is in this family, a very young child had 2 mutations, and it appeared that this was exactly the same mutation as in the Russian-German I showed you before. And this homozygous condition here led to the situation that this girl died in hospital with a severe cardiomyopathy. And this girl here did not reach transplantation. She was listed for transplant, but did not survive the waiting list. So what is interesting with that? Because this is a known mutation. But the surprising thing was that 25% of these mutations are in myosin binding protein C. So especially this mutation is lethal when it is homozygote, and this can be confirmed by our clinical situation. But what is interesting as well is that 25% of the HCM cases in the Netherlands are carrier of these mutation. So the question was, is that the identical mutation or the same mutation? So the question was, do they belong together, the Russian Germans and the Dutch people? Well, with Peter von Tinteren, we made a haplotype analysis, and what you see here is the GR2. This is the homozygote patient I showed you before, the early childhood severe cardiomyopathy, and what you can see here is the haplotype, the chromosomal markers in the neighborhood of this mutation. And what you see here is that the haplotype is really identical in both alleles. It is identical as well to a Dutch control. And the patient who died suddenly by sudden cardiac death has the same haplotype as the other two patients. So in other words, it's the identical mutation. And obviously what we learned so far, and the investigation is still running, this haplotype appears to be the most oldest haplotype among the well-known mutations in this with this variant. So this is identical. So why does this happen? What do we have to do with patients coming from Omsk? Well, the situation is after the wall was down, a number of families with German origin settling in Russia for centuries came over to Germany, and you see here in our center and surrounding, you see all those cases, all the population where we have Russian passports as well. So we have a certain density of Russian Germans here surrounding our center. Well, this has to do with the German history, because after the 7 Years' War, Katharina the Great was advertising for settlers, for German settlers, and they were traveling in the 18th century to Russia, and a number of them were settling in the southern part of the European part of Russia. In different, they were marrying each other, and they represented a certain minority in Russia for decades even. Well, but during World War II, those were deported, displaced to the non-European part of Russia, and especially to Siberia. And in Omsk, we still have a high proportion of Russian families with German origin. But this is only the one part of the story. The whole story might be that the Mennonites started earlier to move to Russia as well. And this is shown here on the left side of the map. So this is taken from the early 16th century, when Menno Simons was one of the Reformators, the Protestant Reformators, who was a Baptist, and these Baptists were settling around Amsterdam. And if you could recall the map from the Netherlands, the certain density of these mutation is around Amsterdam, surprisingly. So those families traveled between 1530 and 1800 to Russia as well. And some of them were traveling back to the western part of Europe and were settling now in Germany. And I was quite proud and happy that Anna Kostareva was contacting the Russian part of the family who was still living in Omsk, and she made some genotyping, and we hope that parts of this family who are affected by this damn mutation is really now under medical control. And I'm very happy that we could collaborate on this distance. I would like to summarize. Some unexplained death cases should be investigated at least by saving a blood sample. So this is most important to analyzing sudden cardiac death to my mind. Autopsies are an excellent source to unravel a structural heart disease, of course, but biomaterial might not be suited for high-throughput screening. In the Russian-German family population and of an old European founder mutation exists, and I'm quite sure in Russia there will be more families carrying such mutations. It would be really interesting to collaborate. So their identification may save lives. So an intensified collaboration between Russian and German experts would be really helpful, and I really hope to collaborate in future. So the ERC guideline, as I've shown before, is to my mind not really sufficient to cope with this problem. So there should be a routine procedure to save and to storage a blood sample from sudden cardiac death victims by the emergency medical doctors. So we are grateful to support of the affected families, first of all, who gave support to the study in the most worst stage of their life. So these are really, really bad conditions the people are in there. We are also dedicated to the prosecutors in the cities, the staff of the criminal police departments. We have been really surprised to get such a support from the criminal police. Emergency medical doctors, emergency medical service teams, pathologists, forensics, medical services, and caregivers of the hospitals were also involved, and I thank you for your kind attention.
Potentially are now under observation. I think that unfortunately at our section we have to round up. So I apologize to Elena Vasichkina for being so late, and unfortunately we cannot listen to her presentation because now there will be a plenary session here and we'll have to move away. Thank you very much for your attention, and we'll welcome you at our pediatric sections that will be held today as well. Thank you very much.